Welcome to the final part of the Hyponatremia series. In part 1, we built the framework. Part 2 ran the algorithm. Today, we get to the dangerous part, which is the management. Diagnosis itself was the easy half, but safe correction is where the patients can get hurt and can have complications. Today, we will cover 3 cases, chronic, acute with autocorrection, and a severe symptomatic hyponatremia case. And we will walk through the correction rate ceiling, hypertonic saline, osmotic demyelination syndrome, and the rescue maneuver when the sodium has been corrected too fast. Before we move on, let's look at the 6 anchors from the first 2 parts and the first 2 videos. Number 1, the rate of sodium drop matters more than the absolute value in itself. Number 2, the tonicity is the first branch point in the diagnostic workup. Number 3, the volume status is the second diagnostic branch. Number 4, the urine studies, including osmolality, sodium, and chloride, will give you the final confirmation of the workup. And number 5, the ADH sits at the center of almost every hypotonic case. And number 6, when the biochemistry cannot decide, you reason to commit with clinical reasoning using the drug timing, demographics, and the reversibility. And you need to hold on to these 6 because every management decision in this part 3 hinges on these 6 items. 4 objectives in this series, which are covered on the left side of the screen. First of all, the correction rate ceiling, 8 to 10 millimoles in the first 24 hours. This is the single most important number in this video. We will come to that later. Number 2, the use of hypertonic saline. When to use it, what are the clinical indications, how to dose it safely, and what are the targets. And number 3, we will go through 3 clinical cases in full using all these principles. And number 4, the osmotic demyelination syndrome cliff plus the rescue maneuver if you head into that territory with your patient management. On the right-hand side, there are the warning signs. Osmotic demyelination syndrome, which is irreversible and devastating. And most importantly, it's entirely preventable if judicious clinical approach is used. And if overcorrection is caught early, the patient can be rescued with Dextrose and Desmopressin. The master management algorithm for hyponatremia. 4 decisions, always in this order, every patient. 2 relate to the patient presentation and 2 relate to the management. What are the 4 principles in terms of the names? Number 1, is it acute or chronic hyponatremia? Number 2, is it symptomatic or asymptomatic for my patient? Number 3, what is the correct ceiling that I have to set for correction of the sodium? Number 4, how to monitor and adjust the treatment accordingly. Now, whether it's acute or chronic, the 48-hour is the cutoff window. If it's less than 48 hours, the brain has not adapted. If it's above 48 hours, there is sufficient time for the brain to adapt to the changes, and hence the risk of demyelination is pretty profound if you aggressively raise the serum sodium level. Now, number 2, symptomatic or asymptomatic. Are the patient's symptoms really severe, like seizures, coma, vomiting, obtundation? Because all of them will demand urgent hypertonic saline use regardless of the duration, whether it's acute or chronic, because you need to protect the brain. Otherwise, the treatment is rate limited. We will come to that in detail. Third point, setting the correction ceiling. We've already discussed that the maximum recommended ceiling is 8 to 10 millimoles per 24-hour window, especially the first 24 hours. But in high-risk patients, you have to tighten it further to 6 to 8 millimoles. However, over a given 48-hour period, initial 48-hour period, the total correction recommended is not more than 18 millimoles per liter for sodium. Point number 4, monitor and adjust. Really crucial. You need to recheck the sodium and after 1 hour, 2 hours, 4 hours, 6 hours, and 12 and 24 hours. And if you're overshooting, you need to readjust, pull it back by giving dextrose with or without desmopressin so that you reduce the risk of osmotic demyelination syndrome. Coming to decision 1, is it acute or chronic? The 48-hour rule applies here. Acute means if there is a confirmation of less than 48 hours of the timing of onset, which means the brain has had the time to adapt. What does it mean? The brain cells have not had time to remove the osmolytes from the cells to the outer milieu. And that means that, the hyponatremia, it risks this cerebral edema because the fluid, extracellular fluid is dilute. It is a lot of water, and the osmolytes are intracellularly. They will pull the water inside, and that leads to cerebral edema, which can be very dangerous. Aggressive correction in this situation is indicated and safer because you want to protect the brain. That is a priority. In chronic, if the duration is 48 hours or more, the brain had time to adapt, which means osmolytes have seeped out of the brain cells and have equilibrated. Now the brain cells have shrunken, which means it's chronic hyponatremia. And if you try and correct it rapidly, then what will happen is the sodium will rise. It will be concentrated extracellularly. Has the higher sodium, which you've just given now, has turned the dilute component of extracellular fluid to more concentrated. That will suck the fluid out of the cells extracellularly, leading to osmotic demyelination. The key decision will be look at the precipitant. Anything happened in the last 48 hours? And a surgery, IV fluids, ecstasy use, marathon running, vomiting, etc. If there's a clear cut precipitant. Previous labs will help if you have available labs within 48 hours, if the patient is already there. If the duration is unknown, then it's safer to treat as if it's a chronic one. Decision number 2, symptom severity. 3 categories with 3 different responses required. Severe symptoms, moderate symptoms, and asymptomatic patients. In severe symptoms, like seizures, coma, obtunded GCS, profuse vomiting, and cardiorespiratory distress, this is a medical emergency, and you have to protect the brain and the condition, assuming that it's causing neurological problems. So this is a medical emergency. Hypertonic saline needs to be initiated as soon as possible with close monitoring and high dependency level or ICU level care required if required. Now, regardless of whether the patient is acute or chronic hyponatremia, this is indicated because of the symptom severity. You just have to protect the brain. The target rise should be 4 to 6 millimoles per liter, which is enough to relieve the symptoms, but do not keep pushing. So we'll come to the management part later on. In the second category of patients with moderate symptoms, which means symptoms like nausea without any vomiting, mild headache, mild confusional state, unsteady gait, and falls, you need cautious correction. And frequent and hourly reassessment is really, really important. If no improvement, then you can escalate to hypertonic saline. The asymptomatic patients, which will form the bulk of our patients on the wards, especially in the medical wards actually, these are the patients who barely have any symptoms as such, like neurological symptoms, and these are the chronic hyponatremia patients. In this situation, monitoring underlying etiology, assessment of the causes, drug history, that is more important than the actual correction of sodium as such. However, if really indicated or needed, then the target setting of 8 to 10 millimoles recommended. Remember our aurum beetle, like gold standard. For normal patients, anyone with high risk of osmotic demyelination, the ceiling is 6 to 8 millimole correction. We will discuss it later. Setting the correction ceiling. Now, these are the most important numbers in this video to remember. So we will come to the mnemonic later, which I developed myself actually. Anyhow, the standard ceiling is number 1, which is 8 to 10 millimoles per liter per 24 hours. We have discussed it again and again. This applies to most of the patients, except the high-risk patients, in whom the target correction will be 6 to 8 millimoles per liter in the first 24 hours. Basically, we will discuss later, but the real high-risk patients are the chronic alcoholic patients, or who are and anyone who is malnourished, hypokalemic patients with liver disease, and any chronic patient in whom the serum sodium is less than 105 millimoles per liter. The total 48-hour correction limit is 18 millimoles. Let's say you have corrected the 10 millimoles in the first 24 hours. So the target for the next 24 hours will be an additional 8. So that is your allowance to make it 18 in total. And secondly, the rise of the first 24 hour, that is 4 to 6 millimoles in the first 1 to 4 hours we've discussed before in acute severe symptomatic hyponatremia. And that's enough to relieve the cerebral edema, and then you can look at the 24-hour correction and targets and committing to. Now, one mnemonic that I had developed for myself, which I think it might work for you, is think of the numbers as 4 to 6, 6 to 8, 8 to 10, and then 8 and 10 together becomes 18. Okay, so it's in sort of reverse order. So 4 to 6 millimole correction for acute symptomatic severe hyponatremia in the first 4 hours, 1 to 4 hours. So that's 4 to 6 millimoles. Then 6 to 8 millimole is the target correction for the high risk population in the first 24 hours. So that's 6 to 8. And then 8 to 10 is a standard correction in most of the patients, hyponatremia patients, for the first 24 hours. And then 18, which is a sum of 8 and 10. 18 millimole is a target for the 48-hour correction. So 4 to 6, 6 to 8, 8 to 10, and then 18. Decision number 4, monitor and adjust. The final step, and it is one of the most under-specified. Now, setting the ceiling in stage 3 or decision 3 is not enough. You have to enforce it with active surveillance. 4-step loop is simple. Draw sodium, calculate the rate of rise, compare against your ceiling, and then either act or hold, and then repeat. 4 intervals to memorize. After every hypertonic saline, repeat sodium at 20 minutes. Secondly, you have to repeat it at 1, 2, 4, and 6 hours. And what are the targets? If you remember, I discussed by mnemonic with you, 4 to 6, 6 to 8, 8 to 10, and 18. What are the rescue triggers if the sodium correction overshoots? First of all, if you achieve 8 millimole or more than 8 millimole correction in less than 12 hours, which means less than the recommended window of 24 hours, or you notice that the ADH phenomena is switching off and the kidneys are producing excessively dilute urine, that can lead to dangerous rise in sodium. And for that, 250 ml per hour urine output is considered quite very high. Then you need to give, depending upon your local protocols, so please follow your local institution policy, but the standard recommendation on uptodate.com and evidence-based medicine is 5% dextrose given at 6 ml per kilogram over 2 hours. And usually it's combined with synthetic ADH analog, the Desmopressin, 2 to 4 micrograms IV. And that is actually to prevent free water excretion and just hold on to that water so that the sodium rise is within the acceptable limits. So basically, 2 clinical guidelines provide the foundation for the management of hyponatremia. The 2014 European guidelines, which were published jointly by the European Renal Association, European Society of Endocrinology, and European Society of Intensive Care Medicine. And the 2013 North American Consensus, which was the Verbalis panel. Now, both of them, they provide a foundational framework for the international management of hyponatremia. So where do they sit? They agree on the core principles, which are that severe hyponatremia always triggers the use of hypertonic saline. Number 2, the target rise of initial 4 to 6, remember the mnemonic that I mentioned, 4 to 6 millimoles per liter correction in the first hours, which is up to first like between 1 and 4 hours. And the 48-hour cap of 18 millimole correction in 2 days, that is standard. And osmotic demyelination syndrome prevention is of paramount safety concern. Now, so this is the key thing. That in the 24-hour ceiling, they diverge very slightly. To be honest, it's more academic. The European guidelines caps the correction at 10 millimoles, while Americans give a range of 8 to 10 millimoles. So functionally and practically, both are identical to deliver at the bedside. And the key divergence point comes for the bolus volume. And that is probably the main difference between the two. The European protocol recommends use of 150 ml of 3% saline up to 3 boluses, between 1 to 3 boluses, depending upon the correction response to the correction, while American guidelines recommend using 100 ml bolus volume each. Now, remember, both of them, the target correction is 4 to 6. So practically, both of them work because you have to titrate according to the response. Now, in terms of the rescue overshoot correction, the treatment for the overshooting of sodium correction, both accept using dextrose with or without desmopressin, relowering when overcorrection has occurred. The American panel, expert panel, is more prescriptive on the dosing. So remember the ORM, AU beetle, or our gold standards. These are the gold standard guidelines. Again, the take-home message is that both agree more and they agree more rather than disagree. So my recommendation is just pick one that your hospital uses, which region you're working, judicious clinical analysis of the situation, patient to patient. It will vary, and just follow your local protocols and guidelines. Remember, this video is more of an educational resource rather than a replacement of your clinical practice. Okay, so let's look at our case number 3. You might be wondering why case 3, because this is case 3 in the hyponatremia video series. 1 and 2 we have discussed in the previous videos. We will revisit them again here. Case 3, 32-year-old and an endurance athlete, marathon, was in marathon running today. Drank around 6 liters of plain water during the race, which is a classic exercise-associated hyponatremia setup. Brought to the ED 90 minutes after finishing, confused and agitated, witnessed generalized tonic-clonic seizure lasting a minute and a half, GCS 11, post-ictal, slightly tachycardic but normotensive, mucosae were moist, there was no edema, no focal neurological signs at the moment. Sodium 117, serum osmolarity 244, which is confirms hypotonicity because it's less than 295. Urinary workup, osmolarity 156 above 100. So this means its ADH is on and the urine is concentrated. Urinary sodium is 38, which is again high, and high because when the volume expansion occurs, ECV, extracellular fluid is expanded because of excessive fluid intake. That leads to the body causing the natriuretic mechanism. So ADH is aldosterone is suppressed and natriuretic peptides are released. So that's why sodium is high. Urinary sodium is high. So this is consistent with exercise-induced hyponatremia, and ADH is paradoxically on despite the water loading because of severe stress, exertion, sweating, pain, muscle cramps. All of them, they lead to high ADH. So the duration is less than 12 hours. It's acute, and the patient is quite severely symptomatic with a seizure. And this is classic textbook example of use of hypertonic saline. The use of hypertonic saline is reserved for severe hyponatremia symptoms. 4 indications. Number 1, active or recent seizures. Number 2, coma or deep somnolence with falling GCS. Number 3, profuse vomiting with aspiration risk. And 4, cardiorespiratory distress or impending arrest. Any one of these indications is enough. Acute or chronic hyponatremia in this situation doesn't matter because the severe symptoms and protection of the brain parenchyma is of paramount importance because of the immediate risk of cerebral edema and the associated complications thereof. So the risk here outweighs osmotic demyelination syndrome risk in the short term. However, we have to do it in a targeted manner, and the initial target, as we said, is 4 to 6 millimoles per liter increase over the first 1 to 4 hours, and that's enough to break the cerebral edema cycle. So let's look at the Bolus protocol. Initially, I'll be using the European version, which we discussed before. So first bolus, 150 ml of 3% sodium chloride infusion over 10 to 20 minutes. Recheck sodium at 20 minutes. If the rise is less than 5 millimoles per liter, then give second bolus. And again, same volume, same rate. And if needed, maximum 3 boluses in total once you've achieved the target correction of 4 to 6 millimoles. Then either you stop if the symptoms have resolved or the target rise has been achieved, whichever comes first. The American protocol differs, as we discussed before. The volume is 100 ml rather than 150 ml, but the targets are the same and the logic is the same. Both are pragmatic, both are well validated. Again, use your local guidelines, your hospital policy, institutional policy. This is only an educational resource. I just wanted to compare both together. Now, the expert panel, the American panel, also they accept a continuous infusion of 1 milliliter per kilogram per hour if the bolus cannot be given properly. Now, remember the 3% saline, unlike the 2% or the which we can give on the wards, the 3% saline has to be given through a large bore peripheral cannula or a PICC line, like peripherally inserted central catheter or a central line. So that's why it needs cardiac monitoring, and ideally the patient should be in a high dependency unit or a resuscitation area or ICU setting, whichever your local protocol is. Monitoring of serum sodium level matters equally as the dosing. 3 pillars. Intervals, check the sodium at 20 minutes after each bolus, then at 1 hour, 2 hours, 4 hours, and 6 hours for the first 6 hours. After that, every 4 hourly through the first 24 hours, and then On day 2 and day 3, you can space it out to 6 to 12 hourly. Continuous cardiac monitoring is indicated throughout. Targets, remember, the same principles as we have been discussing. First rise up to 4 to 6 millimoles per liter in the first 1 to 4 hours, hence the frequent monitoring. Number 2, total correction in the first 24 hours should be less than 10 millimoles. And then for the 48-hour total cap is 18 millimoles per liter. So whatever you have corrected in day 1, the balance out of 18 you need to correct on day 2. For high-risk patients, the first 24-hour target is 6 to 8. And remember, when to stop the hypertonic saline, there are 4 triggers. First and foremost, and the most important one is when the symptoms have resolved. So our argentum dove, the balance homeostasis. So you need to protect the brain. Once the symptoms have resolved, just stop. Do not overcorrect. The other criteria are if you have reached the initial target of 4 to 6 millimole correction, or if the serum sodium has reached above 130, or the total correction of up to 10 has been reached as a ceiling in the first 24 hours. So whichever of these comes first, you need to stop the hypertonic saline. The most important principle is symptom resolution rather than correcting the number. Do not treat the sodium, treat the symptoms. And once the brain is safe, you need to stop it. And then again, remember, after that initial phase, the total correction for the first 24 hours and the 48 hour does not change. The limit for those is exactly the same as chronic hyponatremia. Let's look at the management with hypertonic saline for case 3. T0, 150 ml bolus of 3% saline given over 15 minutes. The seizures resolved by the end of this bolus, and the patient is mildly confused with a GCS of 14. Sodium checked at T plus 20. Repeat sodium is 119, which is a rise of 2 from before. So still within the below the target, and the patient is mildly symptomatic. Second bolus given, T plus 40 minutes, bolus 2 complete. Sodium now is 121, which is 4 millimoles rise within the target range. Now symptoms fully resolved, GCS is 15. So what do? We stop it. We don't go further. Then serum sodium monitoring between 2nd and 6th hour revealed with free water restriction rather than active correction. Sodium is 123, drifting up because it's slowly drifting up because the ADH is switching off after resuscitation. Then at 24-hour interval, the sodium is 125, which is 8 millimole correction, exactly within the target range. Patient is asymptomatic and totally safe. 2 boluses, 4 millimole rise in the first 4 hours, then 8 millimole in the 24-hour period. Brain is safe, and osmotic demyelination syndrome risk is minimized. Classic textbook execution. We have 3 management pathways, 1 for chronic and 2 for acute. You need to pick one depending upon the clinical scenario and stick to its ceiling. The chronic hyponatremia, it's slow and there is a ceiling and cap. First of all, try with fluid restriction, 800 ml up to 1 liter per day. Treat the underlying cause, stop the offending drugs, unless the patient is severely symptomatic, which is unlikely in chronic asymptomatic or moderately symptomatic hyponatremia. Correction target up to 10 per 24 hours, recheck every 4 to 6 hours. Then acute non-severe, again, cautious correction. Identify the cause, look at the trigger, restore volume if the patient is hypovolemic, and frequent monitoring. Add hypertonic saline only if symptoms develop, and the same cap as 24-hour normal correction, 8 to 10 in the normal population. High-risk population, 6 to 8 millimoles correction. Crucially, please anticipate the autocorrection. We'll come to that because a patient can overshoot, and that can be quite a severe problem, especially in the hypovolemic cases. In severe symptoms, we just discussed 3 boluses, up to 3 boluses of 150 ml or 100 ml, depending upon European or American guidelines, whichever you're following, or your local institution policy. Frequent monitoring, 4 to 6 millimoles rise in the first 4 hours, not more than that, or if the symptoms resolve. Then you need to revert to the chronic pathway. So once the acute symptoms and the brain has been protected, the rest of the management, the rest of the 24-hour target and the 48-hour is exactly the same. So there is absolutely no difference in that. Only severe symptoms override this early rate, not the total daily volume. So that is a key thing. So please remember that. We will just return to our case 1, which we discussed in our video 1 and 2. The pathway decision clearly is in the right column. Duration is chronic, weak. So that's clearly chronic hyponatremia. So slow correction is needed. Symptoms are moderate, confusion and falls, but nothing severe, no neurological involvement, no hypertonic saline indicated, full stop. Volume status, she was euvolemic, we've already discussed in the previous video. So first and foremost, free water restriction, stop the underlying offending drug, which is a thiazide diuretic, and switch to alternate like ACE inhibitor or calcium channel blocker. Pathway is chronic, and critically, the patient is elderly, frail, chronic hyponatremia. So the ceiling drops from 8 to 10 to 6 to 8 millimoles per 24 hours. Case 1 managed, chronic pathway executed by numbers, and let's look at the trajectory. The management package is on the left and the execution journey and trajectories on the right side. Stop the thiazide, don't re-challenge because of the risk of recurrence. Switch to alternate antihypertensives. Free water restriction of up to 1 liter or 1.2 depending upon clinical situation. Replace potassium also because that will help sodium correction, but it might cause overcorrection. So please be careful, and also introduces the risk of arrhythmias. Apply the ceiling up to 8 millimoles in the first 24 hours, 6 to 8 in her case. Monitor sodium every 4 hourly for the first day and then 6 hourly through from day 2 onwards until sodium reaches above 130, which is a safe range. Trajectory on the right side, sodium 118 at baseline at 6 hourly, and fluid restriction and drug stop, offending drug thiazide, fluid restriction initiated. At 6 hours, sodium is 121, slow rise. 12 hours, it is 123, nice, up to 5 millimole, so within the target range. At 24 hours, the rise is to 7, which is it has led to serum of 125, again within the ceiling. 6 to 8 is our target. At 48 hours, the value is 131, which is very safe, and still within 13 millimole correction in the first 48 hours. The maximum recommended is 18. On day 5, the patient's serum normalizes completely to 138, asymptomatic, discharge planning started, and do not reinitiate the offending medication again. No saline use, no hypertonic use, no rush, just let it settle nicely. So our case 2 returns from hyponatremia part 2 video. The diagnosis was hypovolemic GI loss with free water replacement. Now the management. This case is more dangerous to manage than the case 1 that we discussed, because if you look at the right column, step number 1, she's hypovolemic and ADH is appropriately on because the body wants to hold on to water to defend the volume loss. Step number 2, we gave her normal saline to restore volume. Step 3, suddenly when the volume is replaced, the ADH switches off. And that leads to, because of the volume signal that was driving it is now suddenly gone. And that leads to now, without ADH, the kidneys will be losing massive amounts of free water, diuresis. So they will be in the diuretic phase. And that can lead to overcorrection of sodium, and that overshoots the ceiling and hence risking osmotic demyelination syndrome. Case number 2 management, the autocorrection trap, how was it anticipated and averted in the first place? Management package is on the left side of the screen and the sodium levels on the right side. 1 liter of saline given over 4 hours to restore cautious volume replacement, and reassessment at 4 hours for further need for fluids if needed. Potassium replacement because of 3.1 GI losses. But remember, replacing potassium also corrects sodium because potassium is osmotically active, and when it goes to intracellular compartment, then the sodium comes out due to sodium-potassium exchange, plus potassium also pulls water with it that can lead to the sodium concentration rising in extracellular and intravascular fluids. Antiemetics for symptomatic management, and the standard ceiling of correction in this case is 10 millimoles in the first 24 hours, and you need to monitor sodium every 2 hourly. And watch for urine output because of the high risk of diuresis because of the ADH suppression. Suddenly ADH will be switched off when the volume is restored. And keep the rescue kit ready. Desmopressin, Dextrose, 5% Dextrose with or without Desmopressin. So you will need both. Sodium trajectory on the right side, T is 0, 0 time, sodium 121. Fluids given normal saline for 4 hours. After 4 hours, sodium checked, it's 124 plus 3 rise, which is acceptable. At 8 hours, the sodium is 128. At this point, there is a 7 millimole rise in sodium. Hence, the ADH will be turned off because now there is a big risk of large diuresis because you have restored the volume. There's no need for volume correction. Hence, the ADH will be switched off, and that can lead to massive amount of diuresis. And with that going on, At 12 hours, the sodium correction is now 10, which is what should have been in the first 24 hours. So clearly, the sodium is overshooting. So you give dextrose 5%, and then within the next 12 hours, which is the 24-hour target, the sodium lowering goes back, and it falls back to 129, which means it's an 8 millimole correction, and which is reasonably accepted. Auto correction problem. What is the physiology? So basically, 4 steps. The moment you restore the volume, for example, by giving normal saline in a patient to correct the hypovolemia. So during hypovolemia, the ADH was appropriately turned on because the body wants to hold on to water to restore the volume. So the moment you restore the volume by giving exogenous fluids like normal saline, this trigger is suddenly gone. And that means ADH will be immediately switched off. And the moment it is switched off, the kidneys will start diuresing free water. And that can dangerously overshoot the sodium level in the serum. And that can cross the ceilings. So the 5 high-risk populations or high-risk conditions in which this can occur is, number 1, hypovolemic hyponatremia receiving saline, like our patient in case number 2 that we just discussed. And if you have a patient in whom you stop thiazide suddenly and also you replace potassium particularly, so that's another high risk. Third is cortisol replacement in a patient with Addisonian crisis. And fourth, resolution of primary polydipsia, because the moment that is resolved, the same trigger will be suddenly gone. And recovery from a transient SIADH cause like pneumonia or any intracranial event, or suddenly stopping the SSRIs. In all these conditions, please watch for the urine output. And if you notice more than 250 ml per hour urine output, then you have to give dextrose because it is osmotically active, and also it exerts its tonicity in the plasma, and hence it will retain or hold on to the water in the intravascular compartment and will prevent this excessive diuresis phase and overshooting of the serum sodium levels. So the osmotic demyelination syndrome, which is the cliff which we want to avoid in the first place. Number 1, mechanism. In chronic hyponatremia, the brain extrudes the osmolytes, for example, sodium, potassium, organic solutes, and it leads to equilibration, and hence the volume across the brain cells the osmolality is totally is maintained across, and the brain has now adapted to the hyponatremia in the long run. When you correct the sodium too fast, too quickly, the brain does not have enough time to recalibrate these osmolytes back intracellularly. That leads to the sodium in the extracellular fluid being too high, and that can pull the water out of the brain cells, and that leads to myelin tracts in the pons and elsewhere to demyelinate, and called central pontine myelinolysis or osmotic demyelination syndrome. Now, number 2, the trigger. What is the trigger? If sodium is corrected by more than 10 millimoles in the first 24 hours or by more than 18 millimoles in 48-hour window, the same safe ceilings that we discussed. Risk is worse in high-risk population like chronic baseline hyponatremia, which is chronic, alcoholism, malnutrition, hypokalemia, and also liver disease. Presentation can be biphasic. Initially, the patient improves in first 7 days after correction of sodium, but then rapid deterioration, presentation with symptoms like brainstem symptoms like dysphagia, dysarthria, quadriparesis, and in severe cases, locked-in syndrome, and eventually it may lead to a coma when the brainstem is extensively ignored. Finally, the prognosis. The MRI imaging and the finding can lag the clinical signs by many days. So initial normal MRI doesn't mean it's not ODS. Once it is established, the demyelination is unfortunately permanent, and some functional recovery may be possible depending upon the age, comorbidities, and other factors, but it carries a significantly high mortality of 25 to 30%. Patients at high risk for osmotic demyelination, we've just discussed in the last slide. Number 1, chronic hyponatremia, especially if the duration is more than 48 hours. If you don't know the duration, then assume it's chronic. By default, most of our patients in hospital will be chronic hyponatremia. Anyone with a profound hyponatremia with sodium of less than 105, then the lower starting sodium means you've got a very high risk and very large gradient of correction, and that can lead to high risk of demyelination. Number 3, alcoholism, direct nutritional vulnerability. The beer drinkers' hyponatremia is a classic combination of chronic low sodium plus the thiamine deficiency, and so that's why you need to give high doses of intravenous thiamine. Malnutrition, so again, reduced osmolyte reserves, due to the general malnutrition, poor nutritional status of the patients can lead to brain's inability to adapt properly. And hypokalemia, as we discussed, like potassium replacement can raise sodium directly, irrespective of your other active correction of sodium, and that can lead to overshooting of the sodium correction. And finally, number 6 is the liver disease, pre-existing astrocyte dysfunction. ODS is well described in pre and post liver transplant patients, and extreme caution should be exercised in liver patients with liver disease as well. Dextrose and desmopressin. So first of all, you need to detect it properly. You need to anticipate the urine output going up and the sodium rising rapidly above the ceilings and the threshold. That means you have to act aggressively and preempt. So 5% dextrose given at 6 milliliters per kilogram body weight over 2 hours. Each 100 ml of free water drops sodium by about 1 millimoles per liter. So that's the key thing. So recheck sodium hourly after the infusion. Desmopressin, synthetic ADH analog, and you have to give it at a dose of 2 to 4 micrograms IV, and it can be repeated every 6 to 8 hourly depending upon the response. Now, it keeps the ADH phenomena on because physiological ADH is now suppressed and you are giving synthetic exogenous ADH to keep the anti-diuresis phase on so that the water is still held on to into the body by the kidneys and prevent the rapid correction of sodium. Ultimate re-lowering target of sodium again would be around 4 to 6 millimoles per liter, bringing the patient within that safety window. And then this is clearly recognized evidence-based maneuver, and don't hesitate to use it and follow your local policies. Involve ICU, high dependency unit, critical care, all the specialists and experts as soon as possible. So re-lowering protocol for the sodium, 3 pillars. Number 1, recognition early within hours, not days. If the sodium is rising above 8 millimoles in the less than 12-hour window, the first 12 hours, it should ring alarm bells. Very high urine output, more than 250 ml per hour. So you need to anticipate. Number 2, dosing. So dextrose dosing, as we have said, 100 ml of 5% dextrose should drop the sodium by 1 millimole. So you may need 6 milliliters per kilogram. In a 70 kilogram patient, you're talking about around 400 ml or so. So this will, hopefully it will adjust like around 3 to 4 millimoles of sodium back to the safe range. Using desmopressin is number 3, 2 to 4 micrograms. As I said, recheck sodium at 1, 2, and 4 hours after the injection. Repeat if necessary every 6 to 8 hourly. And then retargeting, again, you have to bring the sodium to within the 4 to 6 millimole range of reduction. And then you need to titrate the 24-hour clock and then the 48-hour clock accordingly. The 6 classic errors which need to be avoided in clinical practice. Each one has a it's an avoidable cause of osmotic demyelination syndrome. Number 1, giving normal saline and SiADH. Isotonic saline actually drops sodium further rather than helping, because the kidney excretes the sodium in concentrated urine while retaining the water. So that leads to worsening of hyponatremia. Number 2, rapid correction in chronic hyponatremia. So capping of 6 to 8 in high risk and 8 to 10 in the normal risk population. If not sure about the duration, assume it's chronic. The contribution of the potassium replacement, as we discussed before, because it's an osmolyte, replacing potassium will also rapidly or significantly raise the sodium correction. One of the key things in sodium correction is frequent monitoring. That's the single most important thing that you can do, and monitoring with active intervention accordingly. And number 5, assuming, as I just said a little while ago, assuming that it's acute. You need to assume that it's chronic so that we are safe in approaching it. And number 6, re-challenging the offending drugs. In our elderly lady with vendroflumethiazide, do not restart it because the risk of hyponatremia in the longer run is significantly grave. 6 commitments. Please memorize all of them when you're attempting to correct hyponatremia. It's virtually a recap. Number 1, acute versus chronic. If in doubt, think of chronic as a default condition. Number 2, the symptoms it trumps the timing. Severe symptoms always triggers hypertonic saline use, whether it's an acute limb or the chronic limb of hyponatremia. But the 24 and 48-hour targets still remain the same. Remember the mnemonic that I told you, 6 to 8, 4 to 6, 6 to 8, 8 to 10, and then 18. 4 to 6 millimole correction in the first 4 hours for acute hyponatremia or severe symptomatic hyponatremia, should I say. 6 to 8 in high-risk population, 8 to 10 in normal population, and if you add 8 and 10 together, I'm just thinking of a mnemonic, the 18 millimole is the 48-hour target. And number 5, rescue is always available. So keep dextrose, 5% dextrose and desmopressin at hand rather than waiting for it to be brought and all that. And finally, look at the cause. Sodium problem is never a sodium problem alone. It's due to a water problem, which is in itself due to something else, most likely medications, dehydration, other factors. So please remember all these 6 principles. Hyponatremia series in 3 videos and 1 slide. Part 1, we built the framework, how to think about hyponatremia. Tonicity is not the same as osmolarity. Volume status actually drives the differential of hyponatremia, and ADH sits at the center of almost every case. Watch for pseudo-hyponatremia and drug traps, and the rate of rate of drop of sodium matters more than the absolute value. Part 2, we laid the algorithm of how to approach a patient with hyponatremia, how to diagnose, how to confirm that the sodium drop is real, assess tonicity and serum osmolarity, clinical assessment of volume status, and reading up the urine osmolarity, urinary sodium, and urinary chloride together. And when biochemistry cannot decide, you need to look at a reason to commit a temporal association of a medication initiation and sodium drop, etc., etc. In part 3, which is this particular video, as you can imagine, we have covered the extensive management, how to treat hyponatremia safely, acute versus chronic, decides the ceiling of treatment. Severe symptoms trigger hypertonic saline irrespective of which side of the algorithm you're on, especially for the first 4 hours. And finally, anticipate the overcorrection. Keep the rescue dextrose and desmopressin always at hand to prevent osmotic demyelination syndrome. Now, I'm really confident that you will be able to run a hyponatremia case end-to-end, admission, workup, diagnosis, management, and a safe discharge.